analysis for an appropriate diagnosis and management. I have no financial interest in this presentation. I'm going to quickly go through the basics of OCT imaging, the difference between the time domain and spectral domain OCT, the spectral domain OCT, macular of healthy eye, and the various patterns to be recognized in OCT and its influence on management in various pathologies. As we all know, optical coherence tomography was first introduced by Huang de et al. It was first described by him in 1991 as a non-invasive, non-contact diagnostic medical imaging technology. And it measures the intensity of reflected near-infrared light, and the time delay difference between the light reflected from different tissue onto a detector is measured indirectly by use of interferometry technique. And we all know that it generates a false color representation of tissue structures based on the intensity of returned light. The warmer colors signify higher reflectivity, and the colder colors from blue to yellow signifies lower reflectivity. And in grayscale, the brighter shades indicate higher reflectivity, and the duller shades indicate low reflectivity. And when there is and an optically empty space looks black. And the image can be compared to an in vivo optical biopsy. And the short it's the source is a broadband light source, superluminescent diode laser, and there is a splitter. It splits half the beam into reference arm, half into sample arm. And the difference between the time domain and spectral domain OCT is that the reference arm in the time domain OCT was a moving mirror, which helps us to detect, which helps us to derive the axial scan, whereas the reference arm in a spectral domain OCT does not move, and the beam which is reflected again passes through the detector region. In spectral domain OCT, it is again split by a dispersive device into various lights of various wavelengths, and then it is analyzed by a spectrometer. It is Fourier transformed, and the final image is obtained. And it's also, so this is also called as a Fourier domain OCT, and it is named after the Baptiste Fourier, the French mathematician who had derived this analysis for calculation. And various OCTs are available in the market. I was privileged to work with 3 of them, and the images which follow are from these 3 mostly. And these give us resolution between 6 microns to 10 microns, and the scanning speed varies from 27 to 40,000 A scans per second. And definitely the image from spectral domain OCT is far clearer, and we can resolve a lot of layers in this. And actually this talk was for a bigger audience. I was expecting some postgraduates, but I'll just go through this also. Light passes through the optically clear space, means the vitreous cavity does not backscatter light, so it appears as optically clear space. One thing about this OCT is that when there is a change in the refractive index between one layer and the other, there is more amount of light which is reflected, and the horizontally placed layers reflect more light. That's why the RP choreography complex reflects, it looks a higher reflective layer, and the nerve fiber layer also looks as a higher reflective layer compared to the other vertically oriented layer like the photoreceptor. And the densely packed layers like the outer nuclear layer, the nuclear layers have got densely packed cells, so they have less backscattering and less reflection. Most of the light is also absorbed, so they appear as a slightly they are appearing as a less reflective layer. So on the whole, the nerve fiber layers looks more reflective. The ganglion cell layer, the inner nuclear and the outer nuclear layer have got lesser reflectivity, and the inner plexiform, the outer plexiform have got a slightly moderate reflectivity, and the external limiting membrane also has a specific reflectivity. It appears as a specific layer, and actually the OCT, though we say that it is an in vivo optical biopsy, it looks like a histological section. Because of the nature that it depicts reflective interfaces, we can see a layer within a single histological layer. Like the outer segment of a photoreceptor has got a densely packed disc compared to the inner segment. So at the junction there is a change in reflectivity. So that is appearing as a specific high reflective band, which is also called as a photoreceptor integrity layer or the inner segment outer segment layer. And this has to be kept in mind. In virtually in all good normal eyes, there is a very good photoreceptor integrity layer, and most of the studies have said when there is a loss in this layer, it can be taken as the photoreceptor layer, and that person is not working sufficiently. And and the other layer which has been described, this is just, I wanted to invert the image to show that these discs are densely packed and there is a change in refractive index, so this appears as a separate layer, the ISOS, and there is another layer which is the cone outer segment tip, which have got another histological character, so that is also picked up as another layer, and further talk, Dr. Umisa will be talking about this layer in particular later on. And this is an advantage of a speculum and OCT, is that we can see a video, and at the site of interest we can freeze it and we can analyze, and we get additional information, or we can interpret a particular information in a better way. And the OCT helps us to talk about things in the qualitative perspective, also in quantitative perspectives. We all have to know the normals before going on to the interpretation of the abnormal. That's why I'm talking a little bit more about what is normal before going on to what is abnormal. And this is an output from a Zeiss Cirrus OCT, and we can see the RP layer separately. We can see the volume which is being analyzed, and the vertical and the horizontal scan. So each of it gives us a specific information, and we would it's better to know the normal before interpreting the abnormals. And everything is about reflectivity in OCT. So we are describing things as hyperreflective, hyporeflective, and a shadow beneath. So few layers which are hyperreflective, like the normal ILM, RP choreographic complex, and in abnormal it's PED or hemorrhage or response scar, and few hyporeflective to mention. And talking about the shadows, the cone effect, some produce shadows and some doesn't. And now coming on to the topic proper. So what is the role of OCT in diabetic retinopathy, vein occlusion, AMD, macro, CSR, and PFT, to mention few common diseases. And the first sign of in diabetic macular edema, the first sign of the edema is the increase in thickening and lessening of the reflectivity, and then due to the fluid accumulation, it has a spongiform appearance called spongiform edema, and when we see this, we know it's going to respond well to the conventional laser management. And the appearance of well-defined cystoid non-reflective spaces termed as it's called a cystoid macular edema, and when we see this, it means that the direct response to laser is going to be poor, and there is a need for further intervention like the anti-VEGF for the IV steroid, intravitreal steroid. And presence of a serous macular detachment should bring us to mind that we have to analyze this patient's systemic parameters properly. So we have to go into further workup of the hypertension and renal parameters. Especially anemia is generally forgotten, it's not supposed to be forgotten. And we have seen patients who are very anemic with this, and on treatment the SMD resolves very well. And when there is a thinning and a photoreceptor loss, always be aware that there is going to be a macular ischemia beneath, and definitely do an FFA to explain to the patient firstly, and to also tell him that there is going to be a poor prognosis in whatever management we are going to do. And so this is an ominous sign, presence of a focal vitreomacular traction, and this is an epiretinal membrane which we have to identify as a separate hyperreflective layer above the surface of the other retinal layers with a thickening, uniform thickening, and this is not going to respond to laser therapy or the intravitreal steroids. So definitely the surgical management is indicated. Promptly refer to a vitreoretinal surgeon. And this is another bad sign, a hyperreflective thickening present in the layers of retina with a very bad, with a good shadow effect. This indicates a hard exudate plaque right at the foveal center, and this person is not going to respond unless, and he is not going to respond to a bigger extent. The visual prognosis is definitely going to be poor, and this indicates that his lipid status has to be properly evaluated, and the physician also has a role to play, and better tell a poor prognosis for such patients. And all the time we don't see things separately, it's going to come as a cocktail. We'll have all these management. So manage the SMD with proper systemic evaluation. CME may require a shot of intravitreal injections, and of course we have to combine it with laser to directly to the aneurysms which are going to leak. And the OCT is also going to help us to see how well we are treating the patient, are we on the right track or not. And so finally, it was helped us in seeing the cause of visual impairment, planning our treatment, and then we can definitely assess whether there's a need for retreatment, and we can assess the location, external pattern with the help of the scar, and presence of absence of macular traction or retropapular traction, which is going to, and few more minutes, few more minutes, and FFA is mandatory to find if there's a CME, please go in for an FFA, and definitely it is useful in follow-up. And subfoveal SRF I've already discussed. In vein occlusion, what is the role? The FFA can be done at a later stage. You can manage the edema based on the OCT, and there's a patient before treatment in CRVO, and after the implantation of Orthodex, definitely it has come down. So what's the role of OCT in CRVO? For diagnosis, definitely not. And it's mainly used for serial follow-up of macular edema, and if you're planning injection, it's a must for follow-up. And we can assess the natural course of BRVO. This patient did not require any injection. This patient is a huge SMD, will definitely require some injection, and this is the picture after management. So in BRVO, it's not for diagnosis, definitely to decide on the treatment, and for follow-up after treatment is very ideal. And in OCT and ARMB has got a lot of roles. We can identify what are the components of the macular, the age-related macular changes, and the RP, as we know, it appears as an undulating. The RP layer is irregular, undulating. These are drusils, and activity can be picked up with the presence of an SRF. And in geographic atrophy, we can assess the thickness, volume, extent, and progression of the area of geographic atrophy. And in exudative ANB, we can point out the activity extent. We can see the response, and we have to decide on the pre-treatment. And these are classical pictures of fusiform enlargement. There is a thickened hyperreflective RP just on top of the RP layer, and with the spaces which shows edema. And this is a picture of a PED, which is an optically clear space, and you can see the RP choriocapillary complex well. This is a fibrovascular PED. Some part of it can be seen, and some part of it cannot be seen because of the hemorrhage obstructing the view. And this is just a video. It was just a video, and then we can identify presence of activity in case of a CNV, in case of a PED, and this is a picture of scar, and sometimes the scar can show activity, so we have to always correlate clinically to see whether it is a scar with CME or is a scar with an active area of CNV. And so this is a patient with scar with CME, and he actually so we have to be careful and decide whether we should treat or we shouldn't treat. And in the pronto, the OCT was taken as a guideline for retreatment. Appearance of SRF in a previously dry eye, and an increase in 100 micron thickness in the center has been taken, and a drop in visual acuity with an increase in fluid. All these are taken as guidelines for retreatment for a case of a CNV. And follow-up, definitely non-invasive follow-up for suspect patient, hydrodrusal pigment epithelial detachment, occult CNVM, and better than FFA to make decision to treat. And RIP, though it can be identified clinically, it has got few features on the OCT because of lack of time. I'm not going into detail of these. And there are specific features for the RAP lesions also. This is a picture of a PCV. It shows a steep PED with a subretinal active lesion, subretinal SRF, and the Epiretinal membrane. This is and we can see all these pseudo holes, lamella. We can differentiate the stage. We can stage a hole. We can identify various factors in hole, macular hole, and identify whether it's a pseudo hole or it's a lamellar hole. And also we can stage the macular hole. This is a full thickness macular hole. So it helps in identifying the hole formating factor, base, RP, whether it is intact or is atrophied, the presence or absence of subretinal fluid, cyst or macular edema. We can decide on whether we should go ahead and operate or tell the patient go and have a poor prognosis, and definitely for surgical counseling and follow-up. So this is a picture of microhole. These are types of hole closure which we can identify. And then CSR, definitely when we don't plan treatment, we can talk about relaxation, yoga and exercise, and we can identify the point of leak. This is just to show that the patient resolved well without any treatment. This is a patient with chronic CSR with a very bad RP. He is not going to respond just with observation. This is just a fish to show that there is a foveal crisis. And in parafoveal telangiectasia, if the vision can't be explained before fluorescinating the patient, we can consider OCT. This is a typical drape sign. And in a pit, we can identify the whether it is communicating with the pit or not, this rises. And this is very important in ophthalmology. One who relies on optical coherence tomography alone is little wise. One who relies on OCT and fluorescent angiography is wiser. And one who relies on OCT, angiography and clinical examination is the wisest. And thank you very much. This is Dr. Preethi.